And we're live. Good morning, good afternoon, good evening, depending on when you're watching the show. This is Marion Spears Carr, and this is the Healthcare Leadership Show, formerly known as the Healthcare Thought Leadership Show. So glad you're here on a Tuesday. I would love to have and know who's watching the show. So please post in the comments and let us know that you're there, and let us know where you're watching from. I'm Marion Spears Carr. For those of you who don't know me, I run a company called Inflow Executives. We're a leadership consulting and executive search firm based in Atlanta, Georgia. Been in the space for a very long time, and this show was my way of sharing the incredible thought leaders within my network, with my network, and beyond. Today, we're talking about meeting the moment, delivering access, quality, and results, the work that's being done at urologylocums.com. And I got really excited about this company and what they were doing and our guest today, because I've always been excited when a physician moves into the entrepreneurial space and tries to solve a problem that no one else is solving, or solving it from a different perspective. My guest today is Dr. Ian Thompson. He's the founder of UrologyLocums.com. He's down in Texas, one of my favorite states. I love working with people from there. Dr. Thompson, thank you for being on the show, and please introduce yourself a little bit better to our
Thank you.
audience.
Thanks for having me. It's been great to be with you today, and just appreciate the opportunity to talk about what we're doing at UrologyLocums.com. So, Ian Thompson, I'm a urologist based in San Antonio, Texas. I grew up here in Texas and did most of my education, except for a stint in Nashville where I did my urology residency training. Came back to Texas, did a fellowship in urologic oncology, and stayed on faculty at the medical school here in San Antonio. Um, Later went to, during that time on faculty, went to business school, and then moved out of academics to take a chief medical officer position with Christus Health, their hospital and the medical center here in San Antonio, and concurrently started a solo urology private practice, something that not a lot of people do, and built that from scratch. And Also later did something similar in an underserved area along the border in Laredo, Texas. Maybe we can talk about that later. But went out really uh, and then did some locums during that time, and we can talk about that later and how that informed my experiences to thinking about what led to starting UrologyLocums.com.
It's great to have you on the show. And like I said at the beginning, what intrigues me always is when I have people on my show who saw a problem that they was in the marketplace and created a different solution to address that problem. And as a urologist, you've worked all over and had this experience. Tell me a little bit about what are some of the key things or key issues in the marketplace that you saw that said, hey, we can do this better.
I think first there was a pretty significant experience I had just working out with a locums with one of the larger established locums companies, and that's through it those type companies through which I worked when I was doing locums when I was working in academics. And I went on assignment down in Laredo, Texas, at a busy hospital to cover for the one urologist that was there for that community. And we're talking about one urologist for over 300,000 people. So a huge need. And we all know there are many areas around the country that have um, uh, limited access to healthcare in general, but especially to a lot of the subspecialties or specialties in general. So um, the nature of the work assignment changed after I'd gotten there, and it significantly had adjusted what I was going to get paid, and it just didn't make sense enough to make me curious and to push back and start asking questions, both of the big locums company I was working for, but also took the time to meet with the CEO of the hospital to explain what was going on. Um, and he was in short, I said, I'm supposed to get paid. I took a week off from my normal job thinking that I was going to get paid this, and this is what they told me. I get down here and I'm going to get paid about a third of what they told me I was going to get paid, and this math doesn't work. And he was kind of flabbergasted. He said, "You're getting paid what?" He goes, "Because we're paying this." And I said, "You're paying what?" And from there I said, "Man, there's got to be a better way to do it." there's got to, if the hospitals, and I've been doing some work with, and this was just prior to me moving into um, healthcare administration, but I'd been doing some work helping along with administration prior to that, and so I knew some of the budgetary constraints within hospitals. I understood that, and I figured there's got to be a better way. There was so much in that margin, based on my what I learned that day, that afternoon, talking with that CEO, that there's a way to save the hospital money and pay the doctor better because the doctor's doing the majority of the work, and there's value that the locums companies, there is work that does get done, so you want to make sure that that's covered. But I it just stuck from there. There's got to be a better way to do it, and you know, push that more of that to the doctor. So
That's exciting. And one of the things that you and I talked about off air, and that I really wanted you to delve into a bit, is when we think about the rural markets, and let's face it, yes, there's massive healthcare organizations all across the country in the major metropolitan areas. In Texas, obviously, there's the Dallases and the Austins and even the San Antonios of the world. But the majority of healthcare being delivered in America today is in the rural or the community setting, and access for patients, particularly to specialty physicians like urology, is very much a challenge. Talk to me a little bit about how you've worked and partnered with these community hospitals, these rural hospitals, to provide urology services incrementally to support those populations so they don't have to travel an hour and a half, 2 hours. Talk a little bit about
yeah.
how that's one of the needs that you've addressed, because I think that's an exciting part of your story.
Yeah, it's something that I'm really passionate about, is just access to care, because from my experience, I know what lack of access really means and what that looks like to the patient. The reality, when we look at the urology workforce statistics, 62% of counties in the United States are without a urologist. And when you think about, and I think it's important to think about the entire supply demand curve of urology right now, where a third of urologists are over 65 years of age, half of them are over
Wow.
55 years of age. And what we know, there's some changing preferences, if you will, about the younger segments of the workforce and where they want to locate, where they want to work. And so that compounds as you have a almost a tsunami of retirements in a lot of these smaller communities of urologists. It's harder to to recruit some of the younger doctors to these areas, because you no longer can you just recruit one. You need to recruit several, because um, the younger folks don't want to come out and be on an island by themselves in a lot of places. So then it makes you the need to think creatively. Going back to that story of when I was in Laredo, I took that down. The reduced amount of time I was working there gave me the opportunity to explore the market, to learn that there was another hospital in town that had been looking for a urologist for 5 years and had
Wow.
no urology coverage. So every patient that came in would be shipped out, up to San Antonio usually. And to put that in perspective, Laredo is the largest land port in the United States, very busy commercially, has a large federal presence, from different um, portions of the administration. They San Antonio is 2.5 hours away, so that's a far bit. And to know that, and at that time, 30% of the people of Laredo were getting their primary care in San Antonio. So that's, imagine a 5 hour round trip for a primary care visit. Around that time, I started noticing, just starting to pay attention of how many patients were in my clinic in San Antonio from Laredo. I would see
Hmm.
12 plus patients some days in my clinic
Wow.
from Laredo, 2.5 hours away. Again, 5 hour round trip to discuss an elevated PSA test, or look at imaging with them, what have you. So I had approached the other hospital down there in Laredo, and long story short, developed a service line where I was able to come down and be their urologist. And I would go down there every other week, spend 2 or 3 days there at a time, see clinic, do mostly outpatient OR procedures, and
Hmm.
then the bigger cases, the bigger cancer cases, I'd bring back to San Antonio. But by doing that, I was able to keep 90 to 95% of those people that I was taking care of in the community locally without having to bring them up to larger. And then they could get all their imaging, labs, everything there. And people don't think about this. The gas money to make that 2.5 hour trip is a big impediment for a lot of folks. And so
Yeah.
when we think of what I call these larger deserts of urologic care that are developing around the
Mhm.
United States, that's real. And so from that experience, I've been able to parlay into what we're doing at a lot of other places. We have the ability to not just put a urologist, but to think constructively with leadership at the clinic and hospital levels with whom we're working to say, okay, do a needs assessment of the community. What does the community need?
Mhm.
And what's best for that? And incrementally can grow and bring in the right skill set doctors to be able to provide um, those services. And so I'm really proud of the work that we've been able to do. I'm surrounded with great people, great team that we're always pushing to be better. So
I love that's kind of where you started and what you're addressing, that your market. You and I've talked about this quite a bit, even though I'm in, by the way, those of you who don't know me, I'm from North Carolina, if you can't recognize the accent, and live in the mountains of Georgia now, work all over the country. But that region of Texas, Laredo, all the way up to Kerrville, down to Uvalde, all around San Antonio, up to Austin, that whole region is an area that I've done a great deal of work in, but also become really close to those communities. And the fact that you're able to help keep those patients in that community, there's a downstream effect also for other services that they have at those hospitals. So that I applaud you for that. Checking in is Michelle Barasa. I hope I pronounced your last name correctly. She's checking in from Manchester, New Hampshire. Tammy Hayer is checking in from Springfield, Missouri. Everybody knows Tammy, super famous in that world. She's excited to be here with us. And if you're watching, please let us know live. I love to hear where our show is being seen and who's out there, because this is how we build our network, is how we grow our audience and really connect them to people like Dr. Thompson. Dr. Thompson, another question I have for you is really centered around the organizations that are out there. How can they get started? So if they are having this leakage of patients because of lack of care, there may be this reluctance to say, well, we need to start a full urology program because we don't have enough patients to support a full-time urologist there. What's the first step in evaluating, can we bring somebody in for 1 day a week or 2 days a week? Or how do you advise these hospitals that know that they need to provide this service in their marketplace, but don't know where to start? I'd love to know about that process.
this is where I really like thinking through um, sort of that needs, almost doing a needs assessment, seeing what's needed there, but also seeing what resources you have at the hospital, the
Mm-hmm.
clinics. um, Having built a urology practice with no loan for myself, with no loan, less than $10,000, that's what it took to get my own practice started. So I have that bootstrap mentality, and I try to share
Mm-hmm.
that with folks because a lot of times doctors come in and say, "I need this, all this shiny objects, all this, great equipment before I can get started." But that all costs money. But how do you
Yeah.
just do the basics? Is there a clinic that you can, could you use the general surgery clinic when the general surgeon is in the OR for a day a week and use their staff? That's how we started in Laredo. I used the general
Yeah.
surgery clinic, trained up his staff to do urology stuff, taught them how to place catheters, did all that, and just incrementally built up from there. And it got to the point that the new patient visits that they were booking were months out. And I said, "This is crazy," and met with administration and said, "We really need more. I just can't be down here all the time." So from there, I would just say that was incrementally 2 days a week, 2 days every other week, then
Mm-hmm.
3 days every other week, then full ultimately. By that time I had built up this company and we were able to come in and bring in doctors, and we staffed them 365, 24/7 for about 3 years, really laid the groundwork as far as, and they were ultimately able to recruit in a full-time urologist that's now there. So we're no longer staffing there because they've been able to build up from having nothing to now they have a full-time urologist there. So I think it's, take a piece at a time. And
Mm-hmm.
it can be overwhelming thinking like of all this stuff that we need, all the equipment and everything, but there are ways to be creative and limit that investment. Just making sure you have good people and a good vision for where you can get. And the nice thing about it, if you want to think about it from a business standpoint, is that pretty much everywhere the demand is going to be there.
Mhm.
except for a few handful of large metro areas. But even there, even in the large metro areas in Atlanta, we see Dallas, we see Houston, see there's still need for urologic services in various places that aren't being covered by the local docs.
Yeah, and yeah, where the at-risk populations are, and ultimately probably don't have access. Your opportunity to work with these organizations to expand and build on the access that they already are providing. That's a great another option. You've got some fans in the chat. John, I'm going to post this because I think it's cool that you have an IT3 nickname, Ian Thompson the third. John Levy's like, he shared such a great story, positive message, and he says IT3 is awesome. So, John, thank you for that message. That's awesome.
Thanks,
It's a
John.
big fan for Dr. Thompson. We have a question too, and I want to get to that question and bring the question up. But for those of you who are watching live for the first time, this is the Healthcare Leadership Show. It used to be called the Healthcare Thought Leadership Show. I've rebranded it recently. We are a show that highlights people that are solving problems in the healthcare industry that are in my network. If you want to learn about the show, want to come on the show to talk about what you do and the problems that you solve, please drop me a DM and we'll get connected offline to talk about it. But Mark has got a question here. What are the best practices being used to manage access given the huge demand? You talked a little bit about that, but he's interested in, is it APP, tiered access based of need, et cetera? What are some of the best practices that you've seen, Dr. Thompson, and that you help deliver? Great question, Mark. Thank you for the question.
I think that APPs play a significant role, and it's all practice dependent, and so forth. And so, making sure that there are now residency programs for APPs in urology. So, being able to recruit out of those programs, those are folks that are ready to hit the ground running, being able to see clinic, do some procedures. But a lot of times APPs are trained in the setting, almost on the job training with the urologist directly. Once they get confident, get going, I think they're critical for being able to see um, new patient visits a lot of times. And so that's classic. I think when a patient gets referred in for an elevated PSA, gross hematuria, blood in the urine, a lot of times kidney stones, and those are great for coming in. They can get the workup going, get labs going, imaging, whatever needs to be done. Sometimes get them set up for procedures. That's how I have a great nurse practitioner that works with me. She is amazing, and she is so critical to what my ability to deliver the quality of care that I want to deliver, because my time is limited. Is being able to, I can't have every follow-up visit, or I may not be able to get them in within the next 24 hours, which sometimes it really helps the patient. But building and cushion into their schedules, they can kind of the nurse practitioner, or the PA can get them in, get the ball rolling, and then say, okay, here's a status of what's going on, and then call me. Oh, can you add them on for surgery today or tomorrow, or instead of them waiting, if they were just to call my office and to say, oh, his next new patient visit is a few months out, and that's what they're saying these days. So we do have the ability to get them in. The other thing is using I think the question was about a tiered consulting service, and being
Yeah.
able to involve, I think nurse practitioners or PAs are great to being able to sift through referrals and figure out what needs to be seen within, you know, pretty urgently within a week or two, or some that have a little bit of wait. We see quite a bit of wait times in a lot of practices across the country, just because the lack of physicians and providers in generals to be able to render that care. And I think it's really incumbent upon us to be able to think proactively, innovatively of like how we're getting these patients in the door, and getting stuff started sooner rather than later to get them taken care of.
Yeah, great question, Mark. Thank you. And if anyone else is watching live or have questions, please post them in the comments, because that's what this conversation is about. Is a live conversation. We want to engage you. We want to answer your questions. Dr. Thompson, one of the things that I was thinking about earlier that we didn't get to talk about in the pre-show was around how does what you do support existing urology practices in these markets? In other words, um, my guess is that obviously you give them some relief so they can have some time off, take their vacations, do those type of things. But what are some other ways that you can help with the services that your team provide that supports existing practices in the marketplace, not only to expand the access, but so that they're a partner with you rather than being in competition or you're just a relief so they can leave for a few weeks or a few days.
Yeah,
Can you talk a little bit about that?
sure. We do the full spectrum to where we come in and we help run entire service lines 365, 24/7, call,
Mm-hmm.
clinic, elective, or to where we, to your point about what I call bench strength, we add a bench strength depending upon maybe it's adding another person with to give a week of ER call coverage to give the
Mm-hmm.
folks that are there full time a break. So, because what's happening, and I see this happen all the time, is that as you see those urologists retire, as one retires, the call burden becomes significantly higher for the people that are remaining behind. And the thing to know is that you're no longer, as a urologist these days, on call for one hospital. Many times you're on call for maybe the entire state or a segment of multiple a large geographic region, because not only is if you've lost a partner there at your hospital,
Mm-hmm.
but in the preceding years, the urologists in the surrounding landscape have disappeared and retired or moved on to where there's better support.
Mm-hmm.
So if you're a healthcare leader in a hospital system or a clinic, is to be able to preserve the folks and keep them retained in your clinics and your hospital there. Start thinking about this earlier before they start asking about it. Get regular pulse checks on the docs that you have there. How are you feeling? Are you good? Burnout is real. And doctors tend to vote with their feet. And so um, get ahead of that, and that it's much easier to preserve and grow a service line from that standpoint, from a urology perspective, than it is to wait till everybody then disappears and then call
Mm-hmm.
us or call somebody else to say, hey, can you come back in and revive this, kind of, help bring it back up. So that's just from call standpoint. But there are practices where we've come in and we've brought an entire like subspecialty care. So they say we've got the bread and butter urology covered, but we would really like to have somebody to come in and help us build robotics. And so we've been able to bring in robotic specially trained urologists into that area that come in on a regular basis, that are able to see those higher complexity patients, operate on them, keep them in the community, and see them in follow up when they come back through. We've been able to do that with also with female reconstructives, especially urology. We bring in
Mm-hmm.
pediatric urology. So um, if you can dream it, I think you can. I always feel like we can figure out a way to somehow do that a lot of ways.
I can see that based on what you talked about at the beginning of this conversation around what your motivation was to create the company urologylocums.com to begin with, was that idea, that gap in what you were being paid and what they were being charged, and kind of that disparity there. I can see why physicians, urologists definitely want to be a part of your group. But one of the things that I've gotten to know about you and about your company over the last several months as we were preparing for this conversation is that you screen, you don't just let any urologist work within your group. Like you set a really high standard in the care that they deliver, but also how they work with the existing organizations. Could you talk a little bit about that? We didn't talk about that
Yeah.
offline, but I really think that's such a game changer and such a critical differentiator about what you're doing. And I would love for you to talk about that.
I benefited and learned a lot serving as a hospital chief medical officer for 6 years, getting to work with hospital leadership, with doctors across all sorts of specialties. But I
Mm-hmm.
really think that the only thing that that really matters is quality, and making sure that you're putting good quality care out there, and that starts with the quality of the docs. I'm blessed to have the opportunity to work with a lot of great colleagues that work with us,
Mm-hmm.
um, and a lot of that comes into how talking. Urology is a small world. Maybe 10,000 urologists in the United States, 10, 11,000, just depends on what data you're looking at.
Mm-hmm.
And so if I don't know them personally, it's 1 degree of separation. Know somebody that knows them or was trained with them, or what have you. Know the programs that folks train are coming from, and so I think that's important. And we do everything we can to vet and dig into it. I- but it's difficult, and I think anybody that's in the business of recruiting docs and
Mm-hmm.
bringing them in from perm standpoint, just the same, is you you got to make sure that it's not just on the front end, but it's also a continual check-in, making sure that, and it's not just with the doc, but it's also our client partner hospitals and clinics. I wish I could say it was perfect, as far as gauging, and
Mhm.
I've learned a lot along the way, and then also making sure that we coach along the way our docs, because each health system's different, the cultures are different, and making sure that we are, working very closely. And I think part of that is just really great communication with our hospital and clinic partners that we're working with. And even here over the last year, just developing new processes into which we're kind of bringing everybody to work with that singular goal of how do we render the best care and deliver to the patients that are coming in the door of that hospital or the clinics in these communities. And I think if you put that as the central focus, that really helps kind of sift through any sort of hiccups or problems that you may have. Like how do we just deliver quality care? Because that's the only thing we have to stand on at the end of the day. I think it's not business, it's not money. It's, are we taking good care of the patient? And I think we can, it's a goal worthy of, seeking. So
Absolutely, and it's such a critical component of having APPs and physicians and everyone pulling toward that patient outcome. And again, regardless where you are, be it urban environment or rural environment, everyone deserves to get the best care possible that's available. And I love that. Um, we were I told you this was going to go by fast. We only have a few more
it
minutes. So
has.
if there's anybody in the audience that has other questions for Dr. Thompson, now's the time. Put them in the chat. We'll get to them. And if afterwards we're not able to answer them, we'll make sure they get answered. Dr. Thompson, one other question I wanted to ask you was, when you look at what you've already talked about, the fact that there's a lot of physicians retiring, the average age of physicians is that are retiring, and that number is staggering, and how many physicians we're losing. And you talked about those numbers earlier. What are some things that healthcare organizations can start doing right now to prepare for even bigger gaps? What are some of the things that they can do in terms of the specialty care, and particularly in terms of urology care? Because as the population continues to age, we know the number of patients that need to see urologists, that number goes up too. What are some things that we've talked about, kind of how to get started, talked about that piece, but what are some things that organizations can do now to go, oh, wait a minute, we in a year or 2 years or 3 years, we're going to be in trouble? I'd love for you to talk about
Yeah.
that.
Start recruiting, making connections. With surrounding residency programs, those kind of things that I know the physician recruiters are probably already doing, and get ahead of it.
Mm,
Don't wait till you feel the need. Just, you got to be recruiting. And if you have the opportunity to hire somebody and they're interested, whether or not there's a job there already, hire them. That's not just for urology. That's for
yeah.
when you find good people, hire them. The job will work itself out later. But for urology, I think that's true. Um, Making sure that when you do have the docs, take care, force preservation, make sure you're taking care of the docs that you have. I cannot tell, I mean, that's probably the most important thing. But then also, and how you do that is make sure that they're resourced appropriately, make sure they have technology, ambient scribe services in their EMR. So how are you reducing the things that are the burnout? You wouldn't believe how many people call me over epic message in baskets. They're looking to leave a job because the death by a thousand paper cuts of the EMR or whatever, they'd rather leave town and go do locums 1 to 2 weeks a month. Because, but if you just solve some of these smaller things, you can retain your docs. And um the call burden is real, making sure you're kind of managing that and that you staff that up appropriately. Um and being the compensation market is changing so quickly. Don't be on the back
Mm-hmm.
end of it. Have those tough conversations internally within the organization, so that when you go to market to go try to recruit that urologist, that you have something that's competitive. And the one thing that I always say that's not never in a contract is autonomy. Nobody discusses autonomy. um, and making sure that that the doctor has, um, and I don't know how to structure that. And people are more putting the things that are the sort of limiting things within the contract, but making sure that the doc has freedom, freedom of controlling their schedule, their time, those kind of things, and engaging, instead of just treating
Mm-hmm.
them like an employee, kind of. So I think that's really important. And when you're thinking about designing a successful urology program, and especially if you're employing them, for instance.
Yeah, I think that all those are a great advice, and from my audience and a lot of the people that I work with are hospital executives, CEOs, chief financial officers, chief nursing officers, physician practice operations people. Hope you took some notes from what Dr. Thompson just shared. If not, you can watch the replay. We are out of time.
Wow,
This I
that was
told you it was going to go
fast.
by fast.
Yeah,
So thank you so much. It
of
was super
course.
fast. 30 minutes goes by fast. For those of you who've been watching this episode, and it's called Meeting the Moment, Delivering Access, Quality Results, urologylocums.com with Dr. Ian Thompson, the third down in San Antonio. Um, this will be saved. If you just go back to the event, you want to watch any part of it, it's also on YouTube at the Healthcare Leadership Show on YouTube as well. And the name of the show is the Healthcare Leadership Show with Marion Spears Carr. Dr. Thompson, thank you so much for being on the show. I put in the comments a link to your website. What's another way that people can get in touch with you? They can connect with you on LinkedIn
Yeah,
or
please send me a message on LinkedIn. That's how people get a hold of me from other healthcare systems when they want to. And I love just chatting with folks. If you want to just talk your urology issues, both on the doctor side or the healthcare system side, to think through, hey, here's where we are. We see this need, or we have a need, or whatever. How would you think through this? And I'll give it unbiased. These are the options you can start considering and help think through that. And if it's something that I could help with, we'd happy to. If it's something there's somebody else that's better at helping you, I'll point you in that direction. Just the same thing with docs that are, if they're considering something different, evaluating the landscape, just reach out to me on LinkedIn, and we'll schedule a call. I'd love to chat with you.
absolutely. Thank you for being on the show, Dr. Thompson. I put in the chat a link to not only to their website, I think that popped up yet, propagated, but link to your LinkedIn. And if those of
Thank
you
you.
who are not connected with me, please send me a connect request. Dr. Thompson, thanks for being on the show.
Thanks so much for having me. This was
Such a
a
great
really
conversation.
a lot of fun. Yeah. Okay.
We're going to close it out. Everybody have a great Tuesday, and we'll see you next week on another episode of the Healthcare Leadership Show. Have a great day.